So the first is like, why are we even talking about this? We're experiencing a mental health epidemic. I think we came up with that language in COVID, and just like it never went away. Things never got calmer and nicer and better. And there's this increase in depression, suicidality, anxiety, loneliness, trauma, and the ways in which we avoid all of the uncomfortable feelings, the self-soothing behaviors, addictive patterns. Major depressive disorder is the #2 reason for mental health disability globally. So it's a huge global impact financially for us, as well as emotionally and spiritually for us as a global community. And in terms of treatment, our current treatment only is helpful for about 30% of the population. So that leaves 70% of the population untreated. Research has indicated that psychedelic-assisted therapies are helpful for upwards of 60%, and the MDMA research indicated that 67% of people after the MDMA research no longer qualified for the for the diagnosis of PTSD. But again, this is not a single dose of MDMA. This is a 6-month experience with 42 hours of therapy. So it's a comprehensive therapeutic engagement, not just medicine. ECT has been the gold standard for severe depression, and research has shown that ketamine is as effective as ECT without the negative side effects, which are memory loss, confusion, disorientation, seizures. And the ketamine research that has been done for the past 20 years, as well as some of the other psychedelic research, helped us to understand other etiologies of depression. So it's not as much the serotonergic pathway. There's also inflammation, neuroinflammation, the glutamine pathway, which ketamine specifically is helpful in addressing for depression. And the studies have really found the psychedelic-assisted therapies to be helpful not just for major depressive disorder, but also anxiety, pain, PTSD, bipolar disorder, addiction, eating disorders, autism, and more. The Western model of psychopharmacology is really limited to the biologic approach, and this reduces symptoms. But I kind of see this as a missed opportunity because these symptoms present themselves to us as signals of a deeper issue. And if we suppress them, then we don't address the deeper issue. With psychedelic therapy, we're accessing the biologic model, and that's super helpful. It tends to need repeated administration of the medicine, but also psychedelic therapy utilizes the experiential and adaptive models. And by experiential, I mean the sort of the felt sense of oneness that people can experience with psychedelics, or even the felt sense of safety in their body that they maybe haven't experienced for weeks, months, or maybe ever in their whole lives. The adaptive model, when I say that, I'm referring to the cascade of changes coupled with supportive therapy. And this can really expedite and amplify change. So plant medicine has been used as long as humans have been in relationship with the earth. And we've been using plants, herbs, trees, roots as medicine, like as poultices for wounds, food, sacred sacraments. Indigenous tribes the world over have been using this for rites of passage and rituals and ceremony. We really started studying this more intensely in the 1950s and 60s. And we were researching not only for medical purposes, but there was a lot of interesting researching done with prison inmates, with theology students, with the military. The research stopped in the 1970s, which was really driven more by political reasons, which is a whole nother topic. And then it sort of cautiously restarted in the 90s. And right now, there's just thousands of research projects across the globe, exploring a variety of medicines. Is this too loud or weird? Or it's cool? Okay. So the research that's done currently across the globe, thousands of research projects, utilizing MDMA, DMT, ayahuasca, psilocybin, ketamine. There's so many different molecules that we're exploring ibogaine for a variety of different ailments, from depression to addiction, bipolar disorder, late stage anxiety associated with cancer diagnoses. Okay, so now I'm going to talk a little bit about the mechanisms of actions of how this is effective. This slide is kind of like, remember, this is your brain on drugs from the 70s. So this is your brain on psilocybin. So on the right is your brain, like normal, and this image on the, well, your right, you know what I mean. This one is the brain with a lot more connections, and this brain has psilocybin on board. This image is from Robin Carhart Harris's research. It's demonstrating increased neural connectivity, which his research led to increased cognitive and emotional flexibility. So our goal in using these psychedelic medicines therapeutically is to harness the possibility and help people to break out of old patterns, old stories. Neuroplasticity is a term that comes up with this enhanced connection, and that term refers to a process of adaptive structure and functional changes in the brain. And again, this is going to lead to the potential of more flexible thinking, feeling, and being in the world. Okay, this is a slide this is an antisocial octopi. This is some research that Dr. Gould Dolan was doing, highlighting the critical learning window, which is like a biologically predetermined phase when, from like 0 to 5, when we're more neuroplastic, able to learn new things, peaks at about 18 months when language develops with more expediency. So the Gould-Dolan lab had a hypothesis that psychedelics could reopen this critical learning window. So they gave MDMA to an octopi whose critical learning window had already closed, and he was like not social and irritable and mean, and they gave him MDMA and they put him in a tank with a couple of other octopi that were already socialized and nice, and he learned to be friendly and amenable and relational, and this learning stayed with him. So when the MD wore off and he was back to his normal life as an octopi, he was a nicer, friendlier, opener octopi. Sorry, you know what I mean. And this research was so robust that the team decided that they would explore if this critical learning window could also be reopened with clients post-stroke. So they're currently involved in some more research where they're giving psychedelics to clients that have had a stroke, and their hypothesis is that they will be able to relearn how to move the left side of their body or speak or write with more speed and ease with the coupling of learning and psychedelics. This is super helpful for us as psychotherapists, though, because it's coupling therapy with the medicine is what's really potent for us. The medicine itself could be a missed opportunity, but we can enhance our capacity for behavioral change and learn things with greater susceptibility. But we also have to be careful because this is an impressionable phase. So should you give psychedelics to a large group and you wanted to maybe start a cult, it would be easier, and so this in the wrong hands is also dangerous. So it's a sharp tool. Okay, so these are nerve cells. You can see the one on the top is an older nerve cell. What happens with nerve cells is the dendrites kind of atrophy with age. The screen on the bottom has more robust and more dendrites. Dendrites grow out of these nerve cells to help with communication. And this is, I believe, a slice of a mouse brain 1 month after ketamine administration. So as you can see, the dendrites are stronger, more robust, there's more of them available, and this lends itself in an ease of thinking in new and different ways. Okay, so there's a 12-step program called Psychedelics in Recovery. And I saw an article, like their mission articles online, and Dr. Ralph Metzner, who's a pioneer in the field, he's since deceased, but he wrote an interesting article talking about the angle at which we experience life from, and how it's kind of like a 45-degree angle, and how psychedelics expanded to like 180 or even 360. And then he shared a bit that Richard Pryor did when he was having a conversation with his crack pipe, and his crack pipe was like, you don't need the house, you don't need the food, you don't need the wife, you don't need anything, it's just you and me, babe. So he used that to highlight the narrow angle at which we can live in any rigid, locked-in, compulsive, repetitive behaviors, which could be addiction or also OCD, depression, like any sort of narrow scope that we live life in can be opened up with the aid of psychedelics. It's like an expansiveness that gets created. Historically, psychedelics have been used in community, in nature, for rites of passage, healing, in groups, and the potency of the group amplified the experience. There was an article that Dr. Grove, who's going to be here around lunchtime, wrote, Hallucinogens and Redemptions, where he was exploring hallucinogens used for redemption in 4 different areas of the world. And the first one he was talking about was the Native American church utilizing peyote. And it's a peyote ceremony in this image. Utilizing peyote as a sacrament, organizing these ceremonies when members of the community were in need of healing, everybody came together. They also looked at a group of the Uno de Vegetal Church in Brazil, compared ayahuasca use in subjects struggling with addiction to a non-ayahuasca using matched group, and 11 of the 15 subjects stated that the ritual use of ayahuasca had a profound impact on the course of their lives. Subjects reported their daily conduct and orientation to the world around them had undergone radical restructuring. A third place they looked at was the Bwiti tribe in West Africa, utilizing ibogaine, which is an interesting medication. It's used for rites of passage in West Africa, but also microdosing is good for hunting. We have found a lot of interesting use with ibogaine for recovery, for heroin addiction and other addictions, but it's cardiotoxic, so there's still a lot of research to be done to make it safe. And again, it's the power of the group that amplifies the healing for these experiences. And I say that because the 4th region that they were exploring was in the States. And now, you know, in our hands, we medicalize everything. So it's just like one-on-one, structured. But there were some really interesting studies done in the 1950s and 60s. Humphrey Osmond, that's him in the upper right-hand corner next to the little LSD bottle. He was using LSD, he referred to it as a psychomimetic because it mimics psychosis. It gave people what looked to him like schizophrenia. He was using it to study schizophrenia and also for the treatment of alcoholism in both low and high doses. The research demonstrated that hallucinogens shift our perception of reality, offering a feeling of connection and wholeness with a purpose, which could lead to the extinction of self-destructive lifestyle patterns. Research also indicated that people having a mystical experience had a higher potential for change. On the bottom, that's Bill Wilson, co-founder of AA. He also experienced LSD and he found it quite helpful, but politics at the time didn't allow this to be integrated into the healthcare system. And he was struggling and exchanging letters with Carl Jung. So they were exploring their thoughts and ideas on addiction and disconnection, lack of the sacred. And so even after Bill got sober, he was suffering and engaging in this letter exchange with Dr. Jung. And Dr. Jung recommended he find a community and connect to something that he finds sacred, which I feel like might be some of the underpinnings of the development of AA. Okay, now I'm going to shift to more clinical use. I spent earlier in my practice, probably like a whole decade, prescribing medication so that people reduce their capacity to feel. And I say that with some shame, but also our culture in generally taught us to suppress our feelings, ignore our intuition in service of fitting into societal norms. Psychedelics allow us to feel all of our feelings and perhaps notice what isn't right. Much of the trauma we see clinically stems from developmental wounds, and psychedelic psychotherapy is a relational procedure that can offer a corrective emotional experience. Trauma in and of itself limits our capacity for novel thought, and psychedelic therapy can enhance our capacity for novel thought. With psychedelics, we learn to go towards the discomfort within a safe container, and the goal is to heal from the root cause. The therapist's stance is different too. Like Michael Ballard states, we remain ordinary and unobtrusive. The hierarchy is shifted. The participant is the expert, not the provider. Sessions can offer a different level of transparency. I find a lot of times clients want to know if we've had access to the medicine and what our experience was like, and I find sharing that can be helpful. There's also a certain level of physical contact, which is unusual in how we're taught to hold space. Sometimes when people are having a deep experience, holding someone's hand can be really helpful. So if we discuss that and everybody's on board beforehand with consent. Okay, so more clinical. These are the stages of treatment. Assessment. The initial meeting to decide if somebody's medically and psychiatrically cleared or appropriate for this level of care. The preparation phase. This can be a couple of weeks to even a couple of months. This is really, initially it's an informative phase where we talk with clients and we set expectations, try to understand the client's motivation for this type of treatment, and discuss the different ways that they might potentially experience the medicine. And there's a lot of nervous systems that might not be ready for this level of surrender that might be necessary. So working with people to help prepare them can take a lot of good support. The medicine's administered in a medically supervised environment. We monitor for blood pressure and pulse. We have clonidine and Zofran on hand to address any elevated blood pressure or nausea. The whole physical space is structured for safety. Ketamine intoxication is usually about an hour. MDMA and psilocybin is closer to 6 hours. The medicine enhances neuroplasticity. That's a word we've touched on before. And so we emphasize a fertile period after the session. Most potent in the first 48 hours, but can be up to a month, where people are more accessible to developing new thoughts, new patterns, and also because you're more porous, we encourage people to kind of avoid things that they know are going to be really bad for them. And then the integration phase, which is really the most important. And it can also take days, weeks, months, years to make meaning out of some of the experiences that happen. Like I think it took me 5 years to make sense of like an ayahuasca experience that happened in another country many years before. So, and it's not just verbal processing the integration. It can be somatic work, art, walking in nature, journaling, acupuncture, energy work. Let's see. Okay, like we started in the beginning, I just want to acknowledge again set and setting. Set is the mindset of the client coming into the experience. Setting is every sensory piece of information in the room, as well as what's outside of the room, family, culture. I believe Dr. Larry will touch on that in a bit. Psychedelics have been originally offered in nature, in community, and now as we medicalize them, we're chemically stripping away an individual's defenses, allowing them to see and feel what's buried. So we need to create an atmosphere where the individual can feel safe enough to do so without shame or contraction. A feeling of safety is really paramount, so we discuss with clients intentions and we discuss letting them go. Sometimes having a dry run of the experience, like, oh, this is what it's gonna feel like to lie down on the sofa and wear eye shades and have headphones on. Okay, now I'm gonna move into ketamine. Ketamine, most of you probably know of, have heard of. So just to get a sense, how many people here have worked with or know somebody that's worked with ketamine? How many people are familiar with clients or colleagues or somebody that has also worked with psilocybin for microdosing? How about psilocybin for macrodosing, for therapeutic ceremonies? All right, so there's a lot of this already out in our culture, in our community. I meant to ask that at the beginning of the conference, so I just asked it there. So the reason I'm bringing ketamine up is because, hi, am I cool? Ketamine came into our medicine world in the 60s as anesthesia and pain management. It was commonly used in the Vietnam War. Have you heard of the term K-hole? So the original coin of the term K-hole is from the Vietnam War, where soldiers would use it to inject wounded, like if a soldier got really badly wounded, their partner buddy soldiers would inject them with ketamine and put them in the ditch that was dug where they were working, and they would be anesthetized on ketamine in the ditch, waiting for medics to come pick them up, and that was referred to as the K-hole. Bradley?
IP's on the way.
Oh, okay.
You're back.
But it's not on my computer, so I can't tell what I'm doing. So we're using it now. In 2019, it was reclassified as medication for treatment-resistant depression. And initially, the research came out with 6 sessions in 3 weeks. But we're currently utilizing ketamine in a lot of different ways for a lot of different indications. I can't bring ketamine up though without also acknowledging the abuse potential and the addictive pattern that people can engage in. So I do use ketamine therapeutically, but I've also treated clients with ketamine addiction. So I haven't seen anybody actually die of ketamine. It tends to be a mixture of other substances and not great decisions, like with some people we know in the media. But there's definitely something to be particularly careful of in terms of the delivery. Can I just change this so at least I can do it on my computer? Okay. Uh-oh. Can I disconnect from that so I can just talk? Or I just need this to guide me? Oops. Oh, but we need that slide. That's gonna be a good slide. But I don't want to get the notes. Okay, so ketamine-assisted psychotherapy. I'm gonna take, also, this is a moment to make the distinction between ketamine therapy and ketamine-assisted psychotherapy. Ketamine therapy is infusing ketamine into the body. It's the biologic model, might require repeat administrations, but, oh, there's my notes. And it can, see, this is what I tell myself. It can be kind of scary, like chemotherapy. Ketamine-assisted psychotherapy is ketamine offered in a relationship with a therapist. And so it's really kind of a missed opportunity to utilize the ketamine without the therapeutic engagement, but it can also be really helpful. Oh, wait, what am I doing, Bradley? Okay, I can do this anyway. So here's a slide. I can make this, can I make this bigger? Is this a touch screen? No, I don't see where this is on my computer, so.
I'll need a Mac person.
Okay. All right, so you can see the graph. So it's time across the X and intensity is up the Y-axis. You can see the blue line is IV administration. It's kind of on and it's gentle and it goes, but also this line is dictated by whoever has their hand on the dial. So you can dial it up or dial it down. The arc of the green line, you can see this is going to be oral administration. It takes about 20 minutes to come on, lasts for about 20 minutes, and then it wears off in about 20 minutes. With oral, it's a rapidly dissolving tablet or a troche. You have to hold it in your mouth for like 15 or 20 minutes. It's absorbed through the buccal mucosa, and then you're encouraged to spit afterwards because sometimes the second pass swallowing leads to increased nausea. The pink line was intramuscular. You can see it went straight up, and what's it called? The shape of it wearing off, like the slope of it coming down, is dictated by the intensity of by the amount given. Like if you inject somebody with 10 or 20 milligrams, it'll go straight up and then it'll come down and you'll kind of be back in like 15 or 20 minutes. If you inject somebody with 70 milligrams, the angle will go up and it might take somebody a whole hour to come back. The oral bioavailability is between like 20 and 60%, so it's a really wide range, which makes it kind of challenging in terms of coming up with the right diagnosis for the right situation. Intramuscular and intravenous is like 95 to 99% bioavailable, so you know exactly what you're getting. I tend to use pulse dosing, so I use IM, and I kind of visualize it as the appetizer and then the main course. So you can give somebody a shot, and then as I can't remember, I said this already, you start to feel it in 2 minutes, it peaks at 9, and it starts wearing off at about 12 minutes. So you can check in with somebody at the 15-minute point and say like, how are you feeling? And some folks are like, I'm really in a deep place and I don't need to go any deeper. And some folks might be like, I could do long division. So then you go with the deeper dose. Oh, thanks, Dave. Psycholytic versus psychedelic are terms we use when we're talking about dosing and people's experience. Psycholytic refers to a dose that is high enough to melt away your conscious and unconscious defenses, yet low enough to keep you present and conversant in the room. It's actually really good for people that are somewhat rigid and not accessible, but would really like to do some deeper work. And psychedelic dosing is the one where you kind of lose your sense of self. People have like fancier terms, ego death, loss of self. So this is where you're no longer yourself in the room. You have that like larger mystical potential sense of oneness. A lot of people experience ketamine as a slowing down, so you really separate from your reactions. Like you feel it and you see it and you have like an inner witness come online and you're like, oh, that happened and I would usually do that, but now I would like to respond differently and not react. So you really kind of get an inner narrative for yourself. If you offer somebody head shades, eye shades and headphones, you're controlling for 2 of the 5 senses, so you can go deeper without going higher in dose. I'm gonna share a case example, and this is a client, Ted, 60-year-old male, history of alcoholism, 5 years sober, working together for about 8 months. His working diagnosis is addiction and developmental trauma. He previously experienced high-dose ketamine and it was quite effective. This time when he came in, he was like super agitated, really angry, revved up, and so it felt strange to like give him a shot to shut him down. So we shifted to the psycholytic dose so he could be more present with his experience. So I gave him an oral troche. He's holding it in his mouth for a while. I asked if he wanted to pick an oracle card, because I like to try to bring some spiritual thing in where and when I can. He picked, what did he pick? Oh, illuminate your shadow. So I asked if he wanted to work on his shadow parts. He said yes. I had just finished my IFS course, so I asked him where he feels the angry part. He says he feels it, his whole body, arms, neck, back, hamstrings. It's as if I'm coded for violence. How do you feel about that part and what's its job, I ask. He says its job is to protect me from my father. And he did acknowledge that as hard as the angry part tried, it felt ashamed and hurt and tired that as hard as it tried, it couldn't protect me. I asked him, how old does the part think you are? He said, 3, 7, 16, 27. He shared a couple of difficult experiences in his life. And then towards the end of the session, he was able to share that he'd always kind of known that the part was there to protect him, but this was the first opportunity he had to acknowledge the complexities of the part of him with compassion and more profound understanding, that part of him kind of felt embarrassed and was working so hard and not really doing what it wanted to help him with. Let's see, so I want to be mindful of time too. Other clients describe their experiences as like floating, like an Escher painting. You're just like up and floating, seeing the events in your mind's eye pass before you without the emotional charge. Folks have said, I experienced the part of me that really wanted to run away, but I was separate from it. I was able to just witness it. They describe an unblending. They describe it seeing things from different perspectives, really close up and in detail, and then zoomed out and zoomed even further out, like from their whole family structure and then through like all of humanity and all of civilization. So you can see things from a lot of different angles. There's another example I'd like to share so I do this thing called clinician experientials, where we have clinicians that are interested in the ketamine experience come in and have a small group experience together. And so this is from a clinician that's 28 years sober, so we had a couple of interesting conversations about how to orient ourselves to how to think about that. So she described seeing her father, who had died a couple years ago, and seeing him with his mother, who was also deceased, and seeing him for the first time with his like complete wholeness, healthier than she'd ever seen him in her whole life. And he wanted to give her a sense of wholeness and healing and support so that she could have it and give it to her son. See, she actually felt it in her back, in her spine. The whole of her back felt a sense of support. She said, I felt really connected to my ancestry in a grounded way that I had never experienced before. Okay, now I'm going to move on really briefly to MDMA. So ketamine, legal and usable. MDMA is only legal for research right now. It's not legal clinically. Otherwise known as ecstasy, Molly, 3,4-methylene dioxymethamphetamine. It's an amphetamine and a psychedelic, oftentimes used in the 60s and 70s for couples therapy to enhance empathetic communication. The current research with MAPS was using it with individuals for PTSD, and that was the research I mentioned in the beginning, where after the research, 67% of the participants no longer qualified for the diagnosis of PTSD, and again, after this long 6-month, 42-hour experience, not a single dose. MDMA downregulates blood flow to the amygdala, which is like your house of anger and rage. It upregulates the hormone oxytocin, which is naturally secreted during breastfeeding and orgasm. It brings a sense of compassion and empathy for self and others. So with MDMA, clients can revisit difficult memories and reprocess them without the associated charge, the emotional charge associated with the experience. So it was used originally for couples. The research saw it in individuals, but I can also imagine it being quite useful in groups for larger complex situations like governance. Okay, so also I'm gonna go brief with psilocybin. Psilocybin is not a plant or an animal, it's a fungi. It's thought to have a consciousness all of its own. It connects underground. This is the mycelial network that is like a source of information and nutrients that are shared for the whole ecosystem. Here you can see psilocybin is actually a prodrug. It's converted to psilocin in the body, and psilocin is really similar to serotonin. So I think that has also brought the microdosing and the use of psilocin, aka psilocybin, into the field to use it in low doses for antidepressant purposes. Again, not legal, but that's some of the community use that people are talking about. There's a lot of really interesting research being done that Dr. Grove will talk about when he gets here, utilizing psilocybin in reactive anxiety with late-stage cancer patients. It's also been really helpful in smoking cessation, so there's a lot of good research to explore. Loosely dosing. So in research, we tend to use the 3 to 5 gram dose. That's a pretty good, strong dose. Oftentimes you can have a mystical experience, and that has seemed to imply that it gives you a better chance of change. 1 milligram, you'll be altered. You could take a walk in nature with your friends, but definitely don't drive. The microdose, you can see it's at the bottom. It's 0.1 milligrams, so it's 100 milligrams, 0.1 of a gram. So microdosing is sub-threshold. You don't feel it. If you feel it, it's not microdosing. How much time? How am I on time? I'm okay? Bradley?
Beg your pardon?
Do you think I'm good on time?
6 minutes.
6 minutes. Dougie Fresh. Okay, so I'll go kind of quick here then. So psilocybin, bigger experience, last 6 hours. Every trip is different. Bessel van der Kolk shared that when he had his experience, he felt the grief and sadness of everyone that he'd ever sat with. He said it was heartbreaking and heart-wrenching and powerful and healing all at the same time. It seems with the psychedelics we have access to all of the memories in our own lives as well as all in the collective unconsciousness. If you believe in that. Okay, again, not legal for microdosing, but we talked on that a little bit. Really, a lot of positive feedback in terms of the flow state, ADHD, depression, not so much for anxiety. I want to reiterate that what all psychedelics have in common is an increased susceptibility. The capacity for new connections, that's the synaptogenesis and neurogenesis, a feeling of connection with a higher dose. They're pro-social, pro-earth, broaden our perspective, that expansive state of being. Somatically, I wanted to make sure to acknowledge the somatic release that we see with people. I work mostly with ketamine because that's what's legal. So we can actually, as it melts away, these like unconscious holding defenses that we don't even know we're doing, we can see the release of energy. Some people like shake things out and it can be like a big vibrational shake for a while. And that can be incredibly healing. That's kind of a la the idea around the energy you hold in the body that we never, as humans, tend to shake out the way animals do. I want to comment again on integration. Really, one of the most important pieces. Allowing clients to make sense of their experience, to take bits and pieces and glimmers of it and process this with their family, with their friends, with their community, with their psychotherapist. But you also have to sort of be careful about who you share it with, because you don't want what you're sharing to be shamed or misunderstood. So integration is also, again, nonverbal, time and nature, and harm reduction. Who should not take it? This is there's a couple obvious ones, like don't take it alone. Don't take it if you have a fractured ego state, if you're currently psychotic, if you're prone to paranoia, if you're actively abusing what you're thinking of taking. But there's a lot of nuances in how whatever these medicines can be delivered, and what's the container, and what's the intention. And sometimes before even saying no to somebody, like it will help somebody engage in the conversation about potential change. If you're like, okay, it's not off the table, let's be open to why you want to do this, and what are you prepared to, how are you set up to experience the changes that you want to see happen. So it's not as much just the integration. I'm finding the more I practice that the preparation is equally as important and can take quite a while as well. And not all psychedelic trips are good. Sometimes people have really terrible experiences, and sometimes people need a lot of support afterwards. We also work with clients that feel broken afterwards and need support for coming, let's see, I've had a couple clients that have come after big psychedelic experiences that led to psychiatric hospitalizations, and how do you support people and get to understand what really is, you know, those books like The Myth of Madness, did it really happen? Is what you're coming up with that seems super crazy a result of a deeper issue that we can get at therapeutically and heal? So there's just a lot of interesting things to explore. And sorry, I feel like that got a little messy, but I wanted to remember to invite you, if you're interested in the group ketamine experiences, talk to me afterwards. It can be a really healing and community building, thoughtful experience. And I am going to be glad to give the microphone to Dr. Laramie.
Thank you, Dr. Altobelli.
in the end, so I was thinking we could do most questions then.
And we do have a 10-minute break before Dr. Laramie will be presenting prior to lunch. To remind you that the bathrooms and filtered drinking water is in the corridor here to the right. And